Welcome to the 4th annual Brain and Cognition Discovery Foundation conference here in Mississauga. And we're going to get started on time here. We've got an ambitious agenda and many topics that are convergent around brain health and brain function. And certainly if the time to us selling out this program is a reflection of the relevance of the topic, I think we can conclude this is a highly relevant topic to clinical practice. A very brief bio of the Brain and Cognition Discovery Foundation. I started this about 5 years ago as an opportunity, as an ecosystem for research and development, particularly novel, innovative treatments in depression and bipolar disorder, and also an opportunity for us as healthcare providers to have access to very high quality, fresh, off the press education that I think should be quickly adopted into clinical practice at point of care. And really, in fact, I think that no one needs to be convinced that this is an unmet need, that we need to have this type of information available. But I don't know of a subspecialty in medicine that's seen such surreal in such velocity to information coming out. And much of this information, I think, should be implemented and adopted. So we wanted to set this up. It's in place. And we have this information this morning. This will be archived for those who won't be able to digest all the information today. And you can go to our website, bcdfoundation.ca, to find some of the videos. Now, we have various sponsorships, and so folks have brought this their support to this. Many have asked me about credits. You can, in fact, get credits as part of learning projects. I wanted to start off with the content, the speakers, they completely choose their own content. So I thank all of the sponsors for being partners with. We need many partners in psychiatry, in the private sector, to help our patients. It's a win-win, and so we're so glad they've supported us. Now, you have, in fact, handouts, and we do have some bio sketches. I'll keep the intros very brief. Harpreet, Bajal, and both Tom Schwartz, I'll introduce them closer to their presentations, but I thank them both for being here up front, but I'll have a few more words to say about them before we get started. Now, you have in front of you, I believe, some question cards on your table. We're going to have some discussion periods. We have floor microphones. There are team touchpads, I believe. I'm looking out at the floor on your tables, maybe not, but you have cards. And we're going to have some interactive questions for you, particularly before Tom and Bajal's presentation, Harpreet's presentation. Now, with respect to the objectives of this program, we want to bring you up to date as it relates to the thinking around the impact on brain as a consequence of having obesity and diabetes. We're going to talk about select mental disorders, mood disorders, ADHD, and the bidirectional relationship they have with obesity and diabetes. And these, in many ways, are organic organisms to talk about in one, if you will, encapsulated program, that being obesity, diabetes, ADHD, and mood, insofar as they have many determinants in common in terms of pathoetiology. But clinically, yes, it's common, and we're learning that there is, in fact, a lot of cross-talk and a lot of pollination that's crossing across these treatments in terms of how we can treat and manage the disorders. So we're going to, in fact, start off with a broader topic on mood. We're going to focus on diabetes. We'll have a bio break, refreshment break, come into ADHD. Then we're going to talk about inflammation, which has been a very, well, I won't say hot topic. That's an obvious pun, but we'll say it's a hot topic in the area, and then we'll, in fact, break for our lunch. And again, prior to Harpreet and Tom's presentation, we're going to have some questions for you. We're going to ask that a person at your table input the team's response representing the table's consensus, and hopefully there is consensus. Hopefully your table's not Democrat and Republican at one table. It'll be a little nasty if we've got Pelosi's and Trump's at one table, but hopefully there's some type of rapprochement, and then we're going to, in fact, give you some time to respond, have some fun with it. Let's get started on depression and bipolar disorder. I want to bring up to speed in terms of where we're at. These are topics relevant. I think some of the hot topics, I'm going to start off with almost a bit of a kind of a 5 or 6 areas in depression and bipolar that are really the topics, the research vistas of priority. Then we're going to roll up our sleeves, be very practical, and talk about how we can help patients Monday morning. Suicide is part of the deaths of despair. So the deaths of despair are suicide, opiate-related poisonings, and alcohol-related poisonings. This was a figure that I looked at in The Economist about 4 weeks ago, maybe a bit longer. I thought it was a fantastic figure in The Economist. You all know that in the United States there's been a 30% increase in suicide since, about 1999, according to the CDC. And that uptick in suicide in the United States stands in stark contrast to what's occurring globally, particularly in India, China, and Russia, where there's been a significant reduction in suicide. And the conversation about the suicide increase in the United States is a conversation that goes well beyond the scope of what we're going to focus on today. But it does bring us back to today's conversation insofar as the urgent need to identify anti-suicide treatment. Now, anti-suicide treatment would not be in the form of a pill, but a pill could be an important tactic. Lithium and clozapine already have anti-suicide properties. Ketamine is under investigation as potentially anti-suicide, as is rapastinil. We'll say more about that in a moment. This slide is nothing but disquiet. I was at a meeting about 2 months ago in Portland, Maine, just north of the border from Plymouth, New Hampshire. And on the slide, Vermont, New Hampshire have had about a 30 to 40% increase in suicides in the last 15 years or so. And many, in fact, are implicating the opiate epidemic. No doubt it is a suspect, but that would not be a comprehensive explanation. We are also, I think, tempted to speculate that some part of this has to do with access to firearms, but Vivek Murthy, the former Surgeon General of the United States, about 2 years ago made reference to the loneliness epidemic in the United States, and we have this across the world right now being discussed. So, but the point is that we clearly, in fact, are interested in drug development and in treatment development for anti-suicide. I'll come back to ketamine and rapastinil in a moment. So we talk about having what's called diagnostic calibration, which I think is a very, it's got a nice kind of sound to it. Diagnostic calibration. That's the kind of the moniker people talk about, clinicians with good clinical calibration. And what that means in English is my confidence in making a diagnosis supported by objective evidence? And I would say that we have good reasons to not be too confident in our ability to arrive at an accurate diagnosis. If we look at depression and bipolar disorder in 2019, 50% of people with those diagnoses still are not diagnosed either accurately or timely. And all of us, I'm sure, are seeing patients, for example, who actually have bipolar disorder who have not received that diagnosis for many, many years, 5, 10, 15 years after observable characteristics. That is a well-known scenario. I've also, in fact, found myself in my career telling people more often they don't have bipolar disorder when someone has told them that they do. And we call that depolarization. You've been depolarized. And this is actually happening as commonly as is polarizing them, okay? And the point I'm getting at is this isn't just academic. This often means that patients are, in fact, not being provided with the appropriate treatments. There's cost implications to this. We in Canada perhaps don't pay as much attention to the cost implication, but that's a big part of this. But in terms of quality and safety, this is clearly a quality and safety gap. So there's been a lot of interest now in using technology, and we're going to come back to this in a moment, as a capability to help us detect in a timely fashion diagnoses. I know many folks here today work frontline, see a lot of patients, and this ability to disambiguate major depression from bipolar disorder is one that I still struggle with many years now into my career. And there's no shortcuts. It's something that one has to invest the time in. We're all time poor. To really, in fact, sort out what Robin and Gouze called the validators. That is, take a history around the age at onset, the number of episodes, relationship to life events or to so-called reproductive life events. We also talk about the phenomenology, and there's no phenomenology that is pathognomonic of bipolar versus unipolar disorder. That being said, we do have, if you will, within the phenomenology, we have hints. And I have found over the years this little sort of trick of the 4 A's to be helpful for me. If I see someone who's depressed, who's very anxious, agitated, angry, who doesn't pay attention, that person, in my mind, has a very high likelihood of having bipolar disorder. Do those 4 A's, problems with attention, anger, paying attention, and agitation, diagnose bipolar? Of course it doesn't. But it gets you thinking about bipolar. And nobody needs to be told that these are very unpleasant features, anxiety, agitation, anger, and not paying attention. But they're also not very pleasant to be around. So some of you here may be on those dating apps. I won't point you out. You know who you are. And if you put your mug on those dating apps and you say, hello, I like to go to movies and travel, and I'm anxious, I'm agitated, I'm angry, I don't pay attention, no one's going to swipe your way, okay? So people don't want to be around you. And so this also segues neatly into something I just wrote an editorial on, kind of a more of a commentary. Where have all the euphoric bipolar patients gone? Where are they all gone? Who here has noticed that they're seeing fewer euphoric patients and more dysphoric patients? Now, where are they all gone? So I've spoken to colleagues in Thailand, Australia, Saudi, Johannesburg, China. They say, Roger, where's all the euphoric patients? That's why I came into psychiatry. And I say, so we conjecture that this has got something to do with the obesity epidemic. So you're going to be hearing about obesity and diabetes. We're going to be talking about mechanistic overlap. But we have reasons to believe that obesity in mood disorders is changing the phenomenology, making patients more flat, more anhedonic. How often do you see patients now who are flat in your office, who are just blunted, apathetic? Now, part of this is because they're smoking ice cream cone-sized joints. That's part of it. But those people adjusted for, why are they so flat? Why are they so anxious and agitated, so irritable? We conjecture part of that's obesity. Mixed features is very common. About 25% of people with depression have mixed, anxious, agitated, don't pay attention, they're angry. And about 30 to 35% of people with bipolar illness. And I think this really leads us astray when we have this phenomenology. Caroline Park, one of our master's students, is looking at this literature in terms of smartphones and apps and technology. 4 billion people around the world now have a smartphone in their hand. This is a big opportunity afforded. This was a meta-analysis conducted, within the last 2 years, so very up to date. What's the bottom line? Favors the intervention. What this is saying is that using apps favors the intervention. And when I saw this, I thought, okay, I need more detail. And this is a very difficult meta-analysis to really interpret because these are apps that could include reminder texts, take your medication or call your therapist. Some of this could be entering your scores on a PHQ-9. Some of this could be, by the way, your local resource is to go to the Mood Disorders Society, et cetera, et cetera. So very difficult to put this all together. This is Gartner's hype cycle. Many would have heard of Gartner's hype cycle. This is a company, a technology company, that coined this moniker. And it really reflects not just technology, but many, many things in life, where you have this peak of inflated expectation followed by the trough of disillusionment. And many of you are saying, my romantic life is somewhere in between there. But anyways, but we know it's technology and other types of implementation opportunities often in fact find themselves somewhere in between this area. Once all the hype is reduced, then we have more contemplative thought processes going on. That's where enlightenment takes place, and we get into a plateau of productivity. Technology and psychiatry is stuck somewhere right now between the peak of inflated and trough of disillusionment, as is in fact gene testing, which I'm going to come back to in a moment. Now, this is an app that we had developed. This is a passive ambient app, and I'm not getting into the details, but I think any app that's going to require the end user to be compliant or concordant to enter information is never going to make a huge impact. We need to in fact have something that is passive in the background. This is not for you if you're paranoid or you're Edward Snowden. But this is, in fact, something that's going to watch you. It's going to watch you 24 hours a day. And this app has now been validated in people with depression, capable of detecting whether you are depressed or not, simply based on a machine learning algorithm that was able to, in fact, arrive at a diagnosis of depression. And interestingly enough, the purple histogram represents the performance of the app. The orange color with brownish color represents the performance of a doctor. So the app is beating the doctor in detecting depression. And for those who are wondering, this is not new vis-a-vis computers beating the doctor. This is already happening in neuroimaging in other parts of radiology. So you know that when it comes to creative destruction, the radiologists are the first ones who are subject to automation. Said differently, who would you want reading your MRI scan? A radiologist, or you want Watson computer reading it? And we're also seeing a similar outcome in dermatology vis-a-vis reading malignant melanoma. Yenna Lee from our group has just tried to bring together extant literature looking at machine learning. These are computers that learn, and they use multimodal data. And there's a lot of interest in psychiatry with predicting who's going to develop autism, who's going to develop schizophrenia, bipolar, or predicting who's going to respond to Prozac or who won't respond to CBT, as we should be pursuing these questions. And we still, in fact, in psychiatry embrace a fairly simplistic notion that a single blood test or a gene test or a single phenomenology or 5 or 6 variables is somehow going to be able to be predictive. No, it won't. It's going to require a very complicated machine learning approach, and the more variables you put into these computer systems, the more predictive they are. So we are going to be in a position where we can predict who's going to have schizophrenia. Prediction at the level of being scalable, being usable data, and also predicting treatment. But we're not even remotely there yet. In simplistic models of looking at an MRI scan combined with some blood tests is not going to do it. I'm always asked about pluripotent stem cells. What's the latest on pluripotent stem cells in psychiatry? Very, very interesting area. This goes back to 1998 when the capability was described of, in fact, isolating stem cells from embryonic tissue. That raised a host of engineering challenges, and of course ethical concerns were raised about this approach. Subsequently in Japan, the Nobel Prize was given to a person who was able to take human somatic cells and was able, in other words, take your peripheral blood cells or scratch the inside of your mouth and take those cells and reprogram them to induce stem cells. In other words, to almost take them backwards and create stem cells. And that's obviously been very exciting that you can induce a stem cell. And why would we want to do this? 2 reasons. We want to recapitulate to the best that we possibly can the disease state at the cellular level. It is still the case in psychiatry that our animal models are our primary models. Now, most of us would say, I will give some weight to a rat model for schizophrenia or a rat model for depression, but clearly that can't be good enough. So we have this ability to almost recreate the disease state at the cellular level by taking this approach. The second of 2 opportunities is this serves as a platform for us to develop drugs, to develop treatments that can specifically target proteins within the cell from, in fact, the affected individual. Now, one of the challenges with inducible pluripotent stem cells is that when you take an adult somatic cell and you induce the stem cell, you erase the epigenetic contribution. And we know that more than half of the liability to depression is epigenetic. It's around 20% or so in schizophrenia and bipolar, so the erasure of the epigenetic doesn't seem like a good idea. There's now been an updated technology called transdifferentiation that allows us to retain that epigenetic, and now instead of going backwards, taking a somatic cell, go to stem cell, and then induce it into a neuron, the technology can allow you to take, for example, a blood cell and immediately convert it into neuron. So this is something very exciting. It's already being applied in some degenerative diseases like Parkinson's and a few others, and it is catching on now. A big trial right now in Miami, at the University of Miami, using stem cells in mood disorders to see if we can improve cognition. Another area that's, I think, been hot in depression, bipolar, psychiatry in general, is looking at domains. Clinicians, in fact, use the DSM-5 as a way to codify diagnosis, as a way to provide a scaffolding to diagnosis. In other words, as an anti-entropy endeavor, to reduce the chaos, to reduce the randomness. But at the end of the day, we are treating symptoms. We're treating circadian rhythm problems, cognitive problems, problems with attachment, problems with affect regulation. And so the field has really, in fact, embraced dimensions and domains. And I've purposely created this slide because I think for me as a psychiatrist, for over 20 years helping people with mood disorders, what I'm really trying to help them with largely is circadian rhythm problems, problems with motivation and reward, and problems with cognition. And by the way, those patients who come to you and say, I'm tired, what they're really saying to you is, I've got problems with motivation and reward. And patients who say to you, I feel no joie de vivre, they're saying to you, I've got no motivation and reward. So circadian rhythms, problems with reward motivation, and problems with aspects of cognition, which manifests as depressed mood and anxiety, in fact, are what we are trying to do. So a more domain-based approach. And many have heard me talk a lot about cognition, and that's in fact why we're talking about ADHD, diabetes, obesity, and mood disorders all in the same sentence this morning, because this clearly is what's driving health outcomes. Now, nobody, I'm sure, likes to fill out insurance forms for companies, disability forms. I find that to be a quality of life detractor for me, filling those forms out. I really don't like filling them out. I hope I'm not saying anything vulgar this morning by saying that. They're just painful filling out these forms. But we do it. And we fill the forms out and ask these questions, like these sort of like, crystal ball questions when's your patient going back to work? And then you just sort of just create an answer. You have no clue. And so you have, in fact, this there. And I've thought about this for so long. What's driving that is cognition. What's driving that's motivation and reward. By the way, Vivek Murthy, who's the Surgeon General previous to the United States, takes the view that the loneliness epidemic is in many ways catapulted by what's happening in the workplace, because the workplace is moving further away from brick and mortar and more towards virtual. And so the workplace has been the principal social support network for many people, and that's changing greatly. Interesting hypothesis. But cognition is what's mediating health outcome. This is a slide showing that with each episode of bipolarity, you see a further decrement in cognition. That's important because of patients' inability to function, but also the lower your cognitive abilities, the less you respond to treatment. So all of us see patients who've had 2, 3, 4, 5 episodes of depression. We scratch our heads and say, that Prozac or that lithium or that Divalproex doesn't work as well today as it did the first episode. I wonder how come. And one of the reasons is because they have greater cognitive dysfunction. And that is an epiphenomenon of a change in the biology of the brain. And that is a consequence of this progressive process. We're trying to figure out aspects around cognition. This is a meta-analysis looking at cognitive dysfunction in bipolar 1 versus bipolar 2. Taken together, bipolar 1 patients on average have more cognitive impairment than people with bipolar 2, who have more cognitive impairment than people with depression. And people who have PBD, which is psychotic bipolar disorder, NPD is non-psychotic bipolar disorder. Psychosis is a phenomenon reflective of severity. In people who have more severe bipolar disorder, i.e. psychosis, in fact have more cognitive impairment. So it's a 3-hour symposium looking at factors that moderate, mediate cognition in depression, bipolar, but my message really is that this clearly is what's driving the PRO, the patient-reported outcome. It's what's driving the loss of workplace productivity, so-called presenteeism, and return to work. So if your patient's been off work for 12 months or longer, the chances that they're going back to work is less than 20%. And that has always struck me, because when I started my career, I was certainly not as thoughtful then as I am now about the hazards of telling patients to take time off work. I'm going to come back to this in just a moment. We're going to say more about ADHD. Tom's going to cover this greatly, but the point I'm getting at is whether you're looking at ADHD or other conditions, I've struggled to understand, is this truly ADHD in a depressed or bipolar patient who's telling me, you know, Dr. McIntyre, they call me Roger when they're manic. They say, Roger, you know, my mind's distracted, I can't focus, I can't sustain my attention. I think I've got ADHD. Is this depression, bipolar? Maybe it's a bit of diagnostic defeatism. I don't think so. I just don't anguish that question anymore, because I think that the cognitive dysfunction of ADHD is so inextricably intertwined with depression and bipolar, as are the treatments, that I do my best to try and disambiguate this, but I don't really burden myself too much with it. At the end of the morning, just before lunch, I'm going to give you kind of a wiki, succinct, pithy, where are we at now with inflammation in depression. But this has been a very big topic. We've been hearing lots about pro-inflammatory balance, changes in IL-1, IL-6, TNF, all these cytokines. We're going to say a lot more about it in a moment. But just to zoom out a little bit, really in fact what my message is that we have, yes, monoaminergic paradigm for the last 7 decades in psychiatry, and that has furnished for us really a list of around 2 to 3 dozen antidepressants. In addition to that drop-down menu of options, we now in fact are developing viable, scalable treatments for depression, which we're going to talk about, that are directly targeting inflammation. Related to that, we're going to be talking about, in a moment, treatments that target glutamate and GABA. Other treatments that target the mitochondria. The mitochondria has become a very hot topic in psychiatry. I always say that we used to blame moms for everything in psychiatry. Now we blame the mitochondria for everything in psychiatry. We're going to say a few words about that. And we're also talking more and more and more about bioenergetics and insulin and so on, which we'll get into. Now, most of us don't like to be told we look older than our birth certificate indicates we are. Most of us take offense when your friend says, you look older than your age actually is. But in fact, when you have a mood disorder, you have a premature aging condition. And this is something of academic interest. What's driving this? Why are the molecular and cellular signatures indicating that there's premature aging occurring? But let me bring this again back to concrete deliverable. There's a number of treatments, and one I'm working on right now, which is known as a senolytic. That is drugs that can look for changes in organelles inside the cell that indicate premature aging, and to take that molecule out to stop the aging process. And it's a very interesting new type of drugs called senolytics that we're developing for depression and bipolar. Now, we're going to hear from Harpreet, as I said, around the interface of diabetes, obesity, and I just wanted to kind of put this appetizer out there just for a moment. Many would know I've had an interest in insulin for a long time. Insulin's a neuropeptide. It is relevant to neurogenesis, neuroplasticity. It's also a monoamine oxidase inhibitor. And I've always been interested in why my patients who are pre-diabetic or diabetic, why are they always so anhedonic? Why are they so cognitively impaired? Why are they so prone to depression? And like most things in life, a simple answer doesn't always, doesn't exist. But a leading candidate has been disruption of dopamine neurosignaling. So when you diagnose a patient with diabetes or prediabetes, what you're really telling your patient is, you've got a dopaminergic dysregulation disorder, and that's why you're so anhedonic. That's why you are so amotivated. That's why your cognitions are dropping and you're having presenteeism in your job. And it's probably also why you're at risk of depression and Alzheimer's disease. So we'll say more about this in a moment, but this has really caught on. And again, academic, but what's the translation? You and I see patients with depression and bipolar, 50% of them are pre-diabetic or diabetic. 50%. And they're complaining that they can't think, they're complaining they have no joie de vivre, and they're complaining that their medications and their psychotherapy is not working well enough. And we pump them full of more medications, we do all this, we do all that, but I don't think we've been as contemplative about how important it is to tightly control the glucose-insulin aspect as a brain protective strategy in these people. Now, glutamate is the most abundant amino acid. It has a 3 ionotropic and 8 metabotropic receptors, and we've been sort of leaving glutamate outside of the streetlight shine effect for a long time. It's sort of been in the corner, a bit of a wallflower, but it's really now coming in center with drugs like ketamine and rapastinel. No one needs to be told this is relevant and why it's relevant. Yes, it's abundant. It plays a key role in neuroplasticity as well as neurotoxicity. And this is part of really a growing set of treatments, not only ketamine and rapastinel, but drugs like dextromethorphan. Dextromethorphan is a glutamatergic drug, riluzole. There's a long, long list of treatments that are now being repurposed in this area. So let's in fact now just, if we can, come into the clinical ecosystem, very practical. What should I be doing to help my patients? What's new? And we have 3 newer antidepressants in Canada: vilazodone, which is Vibarid; levomilnacipran, which is Fetsima; vortioxetine is Trintellix. We have a set of SSRIs and SNRIs. I still use plenty of meclobamide, 600 milligrams to 1,000 milligrams. I think it's kind of an underutilized antidepressant. At doses north of 600 milligrams, it behaves like an irreversible, non-selective MAO. But for that patient with depression, lots of anxiety, side effect prone, patients who are reporting side effects before you've even prescribed the medication, those types of patients, I find this one works quite well for. And certainly bupropion has been with us for a long, long time. Harpreet will say more about the combination of bupropion with naltrexone as a weight loss strategy. But bupropion also would be in that better tolerated category. So let's move along if we can. I call this the 15% rule. So if in fact a patient has had psychotherapy and or has had medication treatment, and they've had 2 sequential treatments for the index depression, and those 2 treatments have been insufficient or inadequate, the batting average with the 3rd treatment is 15%. So I think you wouldn't need to look very long or hard to your practice to come up with, a fairly large cohort of patients who have had 2 inadequate outcomes on a treatment, on treatments. So we often say that, after 2 treatments that about 60% of patients have achieved remission. That's not been my experience as a psychiatrist. My experience as a psychiatrist is with patients with depression and bipolar illness, when they have 2 treatments, whether that's medication with or without psychotherapy, I have found that the average is much lower than that. Doesn't matter, in fact, what that exact percentage is. I think we all agree it's a very high percentage of people are going to require something different. And it doesn't make sense if someone fails to respond to one monoamine-based treatment after the other to keep giving them more monoamine-based treatments. It just doesn't make any sense, and that's why we're going a different direction. Always keep in mind, revisit the diagnosis, and this message has been, I think, empirically supported for a long time, that the more complicated the depression is to treat, that is, the more severe, the longer it is in duration, the less responsive it is to antidepressants, the more likely your patient has bipolar disorder. And this was a study from Taiwan looking at so-called easy to treat, I don't like that moniker, but it's right out of the article, easy to treat depression versus difficult to treat depression. Again, there's a bit of almost the valence of that language I don't think is quite what it should be. But nonetheless, the point is the more antidepressant failures you have that is difficult to treat, the more likely this person has bipolarity. And I bring that up because of this issue about overdiagnosing and underdiagnosing bipolar disorder. We've got both problems, which equals misdiagnosis problem, and again, always going back to that drawing board. Now, when a patient comes to your office and says, do you think I should go off work for a little while? I'm depressed, the antidepressants haven't been working, and I think I should go off work for a while. Let's start a new antidepressant, and by me just being off work, it gives a better chance of the medication to work. Now, they may not say it quite that way, but that's the gist of what people sometimes ask us, or often ask us. I think everyone's been asked that by a patient. I'm going to say to you, be very, very careful. because the evidence in depression is unequivocal that the person who stays in the workplace will have a better antidepressant outcome than the person who takes time off work. So in other words, when you say, you know, okay, let's take 2 months off or 6 months off or 3 months off, what you have done is you have introduced a non-response predictor to that antidepressant. That decreases the chances. Now, it intuitively seems right. Take some time off of work, hang out at home, and just kind of reboot with an antidepressant. That consistently backfires. Now, I'm not talking about politically charged environments or sick, and obviously there's toxic work environments. We all know that. That's not what I'm talking about. Obviously, that's a different conversation, and sometimes you do have to, well, I would leave that environment. But this is a wonderful analysis. I don't know this person, Ishak from UCLA, but did a nice post hoc analysis of STAR-D looking at outcomes in depression. And amongst people who achieve remission with an antidepressant, they're followed forward for 1 year. Some patients have relapses and some don't. So these are patients who are well on an antidepressant, they're followed for a year, some relapsed and some did not. What they found in this study was that if you have 2 types of patients or 2 buckets, patient bucket 1 is in remission and functioning pretty good. Patient in bucket 2 is in full remission, thanks to the antidepressant and good care, good support, but is not fully functioning. The person who's not fully functioning has a higher relapse rate. So in addition to being less responsive, people who are taking time off work have higher relapse rates. And I think if there's a behavioral activist in the room, they would say that behavioral activation is potently antidepressant. I would say I agree. I would also say this involves cognitive remediation. This involves social support in the workplace, again, assuming a positive work environment. It also involves self-efficacy. It involves economics, if you're getting paid. And so I'm not here to say that you tell your patient, get back to work and pull up your socks. That's not what I'm saying. What I'm saying is that I don't think we've been as contemplative about the hazards by taking time off work as we are now. Now, one of the great aspects of this whole Gartner's hype cycle, the expectations in the trough of disillusionment, I can't think of an area which would really encompass, or really that would apply to more than pharmacogenomics. I can't tell you how often I see patients coming in, hey, Dr. McIntyre, I got that gene site test done, or I got this gene test done, and does that help pick my antidepressants? And I just want to let you know, this is a summary of most of the proprietary products that are out there. There's many out there, heavily promoted by the companies. It's capitalism, they're going to promote it. And I don't think anyone's contesting the theoretical framework of this, vis-a-vis that there's between individual variability in response or propensity to side effects or toxicity. And I don't think anyone's disputing that this probably has ultimately roots in genetic architecture. The premise of these tests is that allelic variation in machinery responsible for breaking drugs down, that is the bioavailability of drugs, the allelic variation of these enzymes changes the blood concentration, and that has implications for efficacy. The second assumption is that the proteins that are being looked at for some of these tests are proteins relevant to the mechanism of the drug, like the serotonin reuptake pump. Well, 2 points. One, we don't check SSRI levels. We don't check SSRI levels because the concentration does not match efficacy. Therefore, allelic variations of drug levels affecting bioavailability would not be expected to affect efficacy. It's called Socratic reasoning. The other part is that the targets are hypothetical targets. We don't know how these drugs actually work. So it turns out, in fact, that when we look at this, Josh Rosenblatt, I think, is here today. Josh is with our team. He's been looking at this and a couple of meta-analysis or systematic reviews of this. We could find no evidence that genetic testing actually improves efficacy outcomes with antidepressants. And initially I thought, a bit surprising. I thought the evidence was more compelling. Well, the American Psychiatric Association's come out, the Centers for Disease Control has come out, and now the FDA in the United States has come out and said cease and desist. Gene testing in psychiatry doesn't work. It's being oversold, it's being overstated, and patients are being harmed. So I just want to let you know that's where we're at. It's a technology that probably has a future, but has not reached prime time as we speak. The elephant in the room is cannabis. And we know that this is a major issue. When a patient asks you, can I smoke weed with this medication? What they're really saying is, I've been smoking weed with the medication for the last 2 years, and they want your blessing. That's what they're saying, okay? So we never talk about weed and the effect on drugs. We always talk about grapefruits and grapefruit juice and the effect on CYP3A4. I've never in my career got into my vehicle at the extortionately priced parkade at the hospital and drive home and worry that I've got a drug interaction on my hands because a patient went to Loblaws and had 6 grapefruits. I've never had that happen to me. I don't get too encumbered by ketoconazole, the other 3A4 inhibitor. What about weed? Well, THC9 and CBD are potent 3A4 inhibitors, and we should not forget that, because this enzymatic pathway represents 30 to 50% of your liver. And if they're smoking it, they're also inducing their 1A2. And that has the capacity for drug interactions. And there's already been cases of clinically relevant DDIs. By the way, if your patient likes to eat brownies with weed in it, that won't cause the CYP1A2 to be induced, because CYP1A2 is induced by polycyclic aromatic hydrocarbons, which is through combustion. And if you're eating the brownie, that won't be an issue. I'm not saying that that's tacit encouragement of weed or brownies. I just want also to state, because there's a lot of questions people are getting around this, it would not be appropriate to recommend recreational weed for people with depression, bipolar, schizophrenia. I can't speak to other medical areas, but it would be highly inappropriate to do that. THC9 is very, very toxic and can induce anhedonia, cognitive impairment, as well as psychosis in those at risk. CBD appears to be a different entity. There's reasons to believe it could be therapeutic. A very nice RCT about a year ago demonstrated unequivocal efficacy in psychosis and schizophrenia with CBD. But again, a lot of replication required, long-term safety required, and certainly quality assurance issues are raised. But my message is that significant inhibition on CYP3A4. Your best determinant as to whether you're on the right track, whether your patient's anxious, depressed, psychotic, or manic, is how's my patient doing in the first 2 weeks? In other words, if that patient's showing some degree of symptomatic improvement in the first 2 weeks, I'm on the right track. If they're not showing any flicker of improvement in the first 2 weeks, that's called negative prediction, the chances are at 8 weeks, they're not going to be on the right track. So in other words, at about 1 to 2 weeks, you already know whether you've got the right treatment for that patient, and that would be the indication to you to increase the dose at 2 weeks in depression or bipolar disorder if you're not seeing any improvement whatsoever. And that, I think, is the most powerful determinant of health outcome. Now, when it comes to treating depression, I mentioned earlier that fatigue, motivation, reward, cognition, circadian, these are key targets for us in psychiatry. Wellbutrin is still a go-to agent for patients who are very fatigued and tired. In the newer pharmacopoeia, Fatsima has come along. It has more of a norepi effect. It helps measures of fatigue, motivation, and apathy. We've been able to show that. So for patients, in fact, who are quite bothered by those symptoms, or said differently, a lot of patients complain of emotional blunting on SSRIs. And very common for patients to say, I feel kind of numbed, I feel blunted, I can't cry as much, I can't even react positively as much, and I feel drugged. And this type of phenomenon, which we don't really fully understand, is more common with SSRI treatments. We don't see it as much with SNRI or with NSRI, and Fatsima is an NSRI. The two histograms at the far right, low MEI means low motivation energy. Patients who are really low motivated, low energy, really benefit from this drug, 20 to 120 milligrams a day. Vilazidone's come along. I'm told by the company that this drug is 10 to 40 milligrams a day, but apparently they're missing their 10 to 20 milligram supply. They sold it out. They're doing, I guess they're very popular. They're still 40s, but the point is this is a newer drug for patients who are anxious and depressed who don't want sexual dysfunction. So we used to give these patients a lot of Zoloft, a lot of escitalopram, I was going to say Lexapro, but Cipralex here. And those are decent agents, but you know the sexual dysfunction rate approaches around 50%, and they have weight gain. This is a drug that can help depression and anxiety without the weight gain, without the sexual dysfunction, and that's been seen. This drug is hypothesized to attenuate anxiety because it has a 5-HT1A effect, and it does not, in fact, cause sexual dysfunction or weight gain. So those anxious patients, which represent 50 to 75% of patients who you don't want weight gain, sexual dysfunction, this one comes in at around 10 to 40 milligrams a day. Now, earlier I talked about, you know, be careful when patients go off work because that decreases response probability. This was a post hoc analysis I did with Trintellix showing that when patients are working, now working doesn't mean working 9 to 5. What it means is volunteering, being a student, part-time, full-time, doing something, getting off the couch, stop watching Ellen, stop watching Netflix, do something. The medication works better. And so people often say, well, let's get the depression better and the function will improve. That's not untrue, but that's not the full story. That's why I'm now convinced that when you diagnose depression, patients have got to get the psychosocial treatment on day one with the medication, and you know, the neuroscience mathematic is 1 + 1 = 10. We've also been able to show, this was a study done by one of our colleagues who worked with us for a long time. She's in med school in Poland right now. This is Mahala Sruba-Manipalai. She did this study with the effort task. It's a motivation task. I'll keep it brief. We were able to show that Trintellix, in addition to improving cognition, was able to improve measures of anhedonia. And this is something I have struggled with for 20 years in psychiatry. How to help patients with motivation and how to help them with reward. So remember, anhedonia is a conflated construct representing the wanting and the liking, the motivational and the liking. And motivation is largely dopamine. Liking is largely opiate and endocannabinoid with a bit of dopamine. They're very different. And many patients you see in psychiatry lack motivation, but they still have reward. That's why they lie on the couch and do nothing and they eat chocolate cake and smoke weed and, you know, and so on. Other patients, in fact, they have more the opposite, wherein they're motivated, but nothing's quite what it used to be. Often patients who've been sexually victimized and traumatized, they often report that, this sense of everything's flat, nothing feels pleasure. They still have the motivation, but there's no pleasure. And we found that, at least with Trintellix, we're getting benefits in both areas. You start a medication, you start treatment, you optimize doses 2 weeks out if the light's not flickering. Let's say you got a maximum dose going on, what do you do next? Well, we have atypicals are the most studied agents. Rexulti is brexpiprazole. It's become really our go-to. It's kind of like Abilify with less akathisia. 1 to 2 milligrams, maybe half a milligram to 2 milligrams. I like the Abilify, I still do. It has a bit of akathisia problem. Getting the right dose is a little bit tricky. It requires a little bit of skill to get that right dose of Abilify. I still use Abilify, but brexpiprazole is a little easier to use. Quetiapine, I've sort of referred to quetiapine as the salt and pepper of psychiatry because clinicians just sprinkle it on their patients just to get the flavor right. And Seroquel, in fact, is probably not appropriate to be used as a sleeping pill. And I see this being passed out like Skittles as a sleeping pill. And so it's not a sleeping pill. It causes diabetes, it causes weight gain, it's sedating. And people say, well, I want sedation. No, you don't want sedation. What you want is your patient to be less anxious and agitated. Sedation usually means they're cognitively impaired. And we don't want that. So I think that we've got cariprazine in the United States. We hope it'll come to Canada. It's a bit like brexpiprazole, taking the edge off the anxious agitation without leaving patients sedated. Olanzapine is a great drug, but just too much weight gain. Parenthetically, later on this year, latest early next year, it is expected, barring any unforeseen, that a new olanzapine is going to come out. It's a combination of olanzapine and samidorphan. It's olanzapine missing 90% of the weight gain, which is pretty cool actually, and we hope it comes to market. Lithium and bupropion, still we use, but not nearly as much as we used to because those studies were largely done in people taking tricyclics and mayos, relatively fewer studies with the newer drugs with lithium in thyroid. Latuda is indicated in bipolar depression. It's a very good drug. One of our, I call it the 3 L's. So patients who come to me with bipolar depression and they say, I've been on Latuda, and they say, it didn't work, what else should I try? I'm thinking the other 2 L's. Lithium lamotrigine. So those are the 3 frontline treatments for bipolar depression, the 3 L's, Latuda, lithium, lamotrigine. They have the best evidence, they work very well. Lithium has a bit of problem with public relations, which is unfortunate because it doesn't need to if it's used appropriately. It's anti-suicide, it reduces Alzheimer's disease. It's an incredible medicine. But Latuda has also been shown to be very effective in treating adults with major depression. So if I have a patient who's got major depression and the patient's anxious and agitated, they didn't respond to brexpiprazole, Rexulti, what I will sometimes consider to help manage that anxiety is gabapentin. I use gabapentin a lot for panic, generalized and social anxiety. But Latuda is indicated in bipolar depression, but we use it off-label in major depression, 20 to 40 milligrams a day, where it actually is very good at really reducing the distress of that particular phenotype of anxious agitation. Mike Face and I just published this paper on brexpiprazole, Rexulti. This drug is being developed as we speak for acute mania, also for PTSD, and for agitation in the elderly. And there's almost kind of a bit of a cynical kind of humor about the study being done in the elderly. This would be the first drug, if it makes it to the finish line, approved for agitation in the elderly, if it makes it. So therefore the label's going to say, indicated for agitation in the elderly, and the black box warning is going to say, don't use in elderly with dementia-related psychosis. So it's going to be quite interesting. But I worked at a nursing home for 2 years. I remember Joel Raskin worked with us, and Joel said to me, I was a fellow in pharmacology, and he said, you're kind of an ambitious guy. On the weekends, do you want to work at a nursing home? Do you like geriatric medicine? I said, yeah, sure. So I worked at a nursing home every Saturday for 2 years in Oshawa, and I had like 60 patients a day and at this nursing home, and they were almost all taking antipsychotics when I arrived. It was incredible. So anyway, that's another story. Okay, so patients, in fact, who are fatigued, who are tired, can't focus, are modafinil, this is Alertec, we still use it. This was a study from Barb Sahakian's group in Oxford, where they showed, Cambridge, where they showed that modafinil can improve cognition in depression. This was a single dose study, details don't matter, but this is a pro-cognitive strategy. Shouldn't surprise you, the American military gives their pilots this drug to increase their performance. And this is one of the very few drugs in psychiatry that improves performance in healthy controls, and we do use it. Psychostimulants, we're going to hear about ADHD in a moment from Tom, but psychostimulants clearly are not antidepressants, but they do target cognition, they do target anhedonia, they're very good for fatigue, and they don't destabilize patients. They don't induce hypomania or mania in patients with bipolar. That's been one of the great canards, one of the great false stories. You can safely use psychostimulants in bipolar, but you want to make sure you're using them in people who have a concomitant agent, like an atypical or one of the 3 L's, to help them, in fact, remain stable. This was, NMS is no mood stabilizer, MS is mood stabilizer, and it turns out that when you give a stimulant to a mood stabilizing agent, one of the 3 L's, for example, there's no evidence of hypomanic destabilization. If it's no mood stabilizer, you give a stimulant, there's evidence of destabilization. So that's the guiding principle. You can use stimulants in bipolar. So in the remaining few minutes, I'll just say a couple of words about these rapid onset treatments. This has been an exciting area. There's that one I made reference to, buprenorphine, samidorphan. That's another drug that is being developed in depression that looks at opiates. Let's just we'll go through this fairly quickly just to kind of give you a kind of a scope. Everyone's been hearing about ketamine. It's been with us since 1962, approved in 1970, so approaching its 50th birthday. And it's available orally, sublingually, intranasally, intramuscularly, intravenously, and with different degrees of bioavailability. And I think by now most have heard that the evidence now supports the assertion that it is efficacious in the short term in treatment-resistant depression, wherein, remember that 15% batting average? Well, that's obviously pretty poor, and it goes down after that. Rates with ketamine are between 40 and 80%, obviously much better than the 15% and lower. There are side effects like dissociation and blood pressure alterations, which tend to be more at the front end versus the second, third, and fourth infusion. I'm often asked about oral ketamine. Josh Rosenblatt had led a review of that, and that literature is not compelling. So we don't recommend oral ketamine. Johnson & Johnson's coming out with the intranasal ketamine pretty soon, we hope. I'll say a few words about that in a moment. We don't really know how ketamine works. There's at least a dozen targets. Some are upstream, some are downstream. So upstream are like dopamine, glutamate. Downstream is like trophic factors, plasticity factors like BDNF, eukaryotic elongation factors, and a variety of other neuroprotective proteins. This was a clever paper from folks at Stanford. I was down at Stanford last week. This is Alan Schatzberg's team. They showed that if you pre-treat patients before they get ketamine with naltrexone, which is a mu kappa delta opiate receptor antagonist, you diminish the effect of ketamine. But the Yale group, John Crystal, who've patented intranasal ketamine around glutamate, they can't seem to replicate this. They think it's all through glutamate. Debates go on. It's kind of fun. We don't really know how this drug's working, but we do know it works, and it works in the short term. Odds ratios, folks, of 10 are really it's amazing. And for the longest time, I thought this is just functional unblinding. The patient knows they're on ketamine, so therefore they're just expecting to get better. People have tried to blind this with benzodiazepines. I think we accept now that this is a real effect. What's so interesting is if you had anxious, depressed patients, many would say benzos take the edge off the anxiety. I certainly agree with that. Turns out that intravenous ketamine is particularly effective in the anxious, depressed patient, and those are patients that are clearly common and clearly suffer from treatment-resistant illness. And we're seeing benefits not just in the anxiety, but extending into the generalized anxiety and the social anxiety. It remains an open question whether ketamine is anti-suicide. It clearly is anti-suicidal ideation. That's not anti-suicide. I always like to make the point that suicidal ideation, non-lethal self-harm, and suicide are not contiguous. They are orthogonal, and one does not lead to the other. So you could be anti-suicidal ideation, but that does not necessarily mean you're anti-suicide. In fact, I don't even think they even predict. So we need to see anti-suicide, but what's there is giving us some reasons to believe. A couple of other areas, PTSD, the intrusion, the avoidance, the arousal phenomenology is all being benefited. You may know that ecstasy is also being studied by the NIH in PTSD, and finally in OCD, which is a very malignant phenotype in psychiatry. This one is also showing some hope of benefit with ketamine, but the preponderance of the evidence is now with ketamine. I'm going to give you the referral. You have the brochures on your desk for our center here in Toronto that we have set up, the Canadian Rapid Treatment Center of Excellence, which is Canada's first ever best practices center for offering ketamine for patients who have treatment-resistant syndromes, which is defined as 2 or more prior treatments. Just around the bases, intranasal ketamine from Johnson & Johnson is being reviewed by the FDA and also by Health Canada. So we cross our fingers. Obviously having an intranasal delivery would be preferred to intravenous. Interesting academic questions about comparative efficacy. And this will not be available at your local Shoppers or Walgreens. Pick up some Doritos, a lotto ticket, and some S-ketamine and run home. It won't quite be like that. It's going to be delivered in a specialized clinic as part of what's called a REMS, which is a monitoring system. And in addition to offering robust and rapid onset, S-ketamine is being looked at as potentially anti-suicide as well. Now, ketamine has side effects. Everything does, including placebo. Dissociation can be seen in the first couple of doses, particularly. This is a newer kit on the block that's in phase 3 development. We're studying this also at the CRTCE. This is rapacinil. Mechanism of action unknown, but there's some thoughts about what it could be. But I'll just leave it for today that it's ketamine with fewer ketamine side effects. It's being studied. Crossing our fingers, in the next few months, the FDA is going to approve the very first ever treatment for postpartum depression. This is a neurosteroid called brexanolone, and this is given to moms who are postpartum, have depression, and within 60 hours of an infusion of this neurosteroid, which is known as an allopregnanolone mimetic that serves as a positive GABA modulator, this drug in fact attenuates the depression. So within 2 days, postpartum depression is put into remission. And so we're hoping that Sage Pharmaceutical from Boston will bring this to Canada if it's approved by the FDA. But obviously this is hugely interesting academically and hugely impactful in terms of the unmet need. Finally, psychotherapy in treatment-resistant depression on its own doesn't seem to really work. But when psychotherapy is added to antidepressants in treatment-resistant depression, it really, really works. And so I'm talking about the medications here today, but again, manualized-based therapies, mindfulness, CBT, IPT, cognitive behavioral analysis system psychotherapy added to medication really provides the best outcome in these patients. So folks, I'm going to stop there. This is actually the referral. You have the brochures to the CRTC for patients here in Mississauga who could be eligible. I'm going to stop there. Thank you very much for your attention indeed.